Welcome, everyone. It's an honor and pleasure to be able to speak with you this afternoon about the role of pathology in cancer care. In my experience speaking with students, I think it probably is worth taking a few minutes to speak about pathology in general, especially I think this is mostly first year students, and I think you've had GenPath, but you haven't had systemic pathology yet. And so you kind of have a little bit of an introduction to pathology, but haven't really gotten deep into the topic. So I'm going to begin with a little introduction to pathology, and then we'll talk in more detail about cancer care. I've purposely left the slides relatively simple. There's only 1 or 2 sentences per slide. The idea is that we can expound on the key points that are present on those slides. And also, I would be more than honored to be able to take any questions along the way. I really would prefer this to be a discussion rather than me just speaking the entire time. So with that said, we're going to talk about pathology and cancer care. And the first part of our discussion will be just a brief introduction into what is pathology. So the word pathology literally means study of disease. Actually, if you really translate it literally, it means the study of suffering. And that suffering would be disease-induced. And so when we talk about pathology in general, we're talking about the study of disease and everything to do with disease. So what's the epidemiology of disease? Pathologists play an important role in understanding that aspect of disease. We play an important role in the etiology of disease and what's driving disease. Etiology just means what causes the disease. We play an important role also in diagnosing disease. We play an important role in correlating the clinical findings of disease with some of the things that I just described. And then we also play an important role in also studying the tissues that are associated, the tissue changes that are associated with disease. So we have multiple hats as the Department of Pathology is concerned. The goal of pathology is to provide clinically relevant data for diagnosis and treatment. And so essentially what we're doing as pathologists is we're interacting mostly with tissue. Sometimes that can be tissue from a biopsy. Sometimes it can be due to removal of an organ, for example, due to disease, or it could even be the entire body at the time of autopsy, although autopsies are relatively rare. And then in addition, we're also talking about any kind of fluids that are removed from the body. For example, blood, bodily fluids, et cetera, are also sent to pathology for analysis. Now, we don't just look at tissue for the sake of tissue, and the purpose of this slide is to sort of highlight that point. We're not looking at tissue trying to just come up with random interesting thoughts about the way the tissue looks, or what we might find in the blood, or the different analytes that we might be looking at. The ultimate goal of pathology is to provide, and I kind of want to circle this word here, is to take tissue and to provide data that's clinically relevant for that tissue. And that data could be clinically relevant in as far as we're trying to make a diagnosis. And it can also be clinically relevant insofar as we're trying to provide information that can be useful for treatment. And so that's what pathology is centered on. Now, in the process of that, we do vet many different aspects of tissues and data points in order to determine what's clinically relevant. So for example, let's say a patient has some sort of disorder with the liver, and as part of that disorder, let's take COVID, for example, because COVID is kind of a big thing now. There were cases in which we received tissue from the lung in the case of COVID, and we were analyzing that tissue to try to make clinically relevant observations that could help to further diagnosis, further treatment, further understanding of the disease in the context of diagnosis and treatment. And so that's the ultimate goal of pathology. And a lot of pathology has to do with making observations, but then vetting those observations against whether or not those findings are actually clinically relevant. And I'm going to point some of these things out as we move along. So to achieve the goals of pathology, we are organized as 3 main sections. Now, this organization doesn't necessarily apply to every single pathology department in the world. However, for the most part, when you look at a pathology department, you're going to kind of find 3 major sections in that pathology department. So the first section is called Anatomic Pathology, and it's also abbreviated as AP. And we'll talk a little bit about what anatomic pathology does in a minute. The second division of pathology is called Clinical Pathology, which is abbreviated as CP. And the third and up and coming section of pathology is called Molecular Pathology. It really, in some places, it's kind of a section of its own, and other places it falls either under anatomic or clinical pathology. But certainly, it's a main, it's a rapidly growing and developing area of pathology. Generally speaking, when medical students are applying for residency in pathology, they will apply for either what's called a combined AP-CP residency, which is a 4-year residency in which a student will learn both anatomic and clinical pathology. And again, I'll talk in more detail about what each of those mean. It's also possible that a person would learn only anatomic pathology, in which case they would be just an AP resident. We call it AP only, and that's a 3-year residency. Or they could do CP only or clinical pathology only, and that's also a 3-year residency. And molecular pathology really falls after those 2. So a person will either do AP, CP, or AP, CP, and then usually they'll do a year of fellowship, which is then considered molecular pathology. So this is kind of the way the departments of pathology are organized throughout the United States, especially. In order to just highlight what each of these sections do, so that you can be more aware, and then again we'll tie this into oncology or clinical oncology in a moment. So anatomic pathology, the way I think about it is that it focuses on organs and tissues. So for example, there's a section in anatomic pathology which is called surgical pathology. Surgical pathology essentially deals with biopsies. That's the number one thing that we deal with, and surgical resections. When we get a biopsy, we're trying to make a diagnosis or trying to make clinically relevant observations and to provide that data to our other physicians that are involved in the patient's care. And so that would be biopsies. And then the second major type of tissue that we receive are surgical resections. So for example, we may receive, let's say there's a biopsy. Let's start from the beginning. A patient has a breast lump. They come in. The lump is confirmed, for example, usually by mammogram and physical exam. The patient will then usually undergo a biopsy. So the tissue will be removed, and there's a couple different types of biopsies. The tissue will be removed, and then that will be sent to surgical pathology. Surgical pathology will process that biopsy. Eventually, we'll place it on a slide. We'll then look at the slide. We'll make a diagnosis. We'll issue a report. Along with that diagnosis, we may provide some additional data that will be useful for determining the best clinical pathway for that patient. And then eventually, the patient will, somewhere along the line, usually get a surgical resection. The surgical resection will also come to surgical pathology. In that surgical resection, we'll analyze the tissue, we'll analyze the tumor, we'll provide some additional data concerning the tissue and the tumor, which will then further the patient's clinical care. So all of that is sort of the big picture under surgical pathology. And just to give you a little idea of what I do, so I'm trained in AP-CP, so that means that I did a 4-year residency, 2 years of AP, and pretty much, let's see, like maybe like 3 years of AP and 1 year of CP. And then eventually I went on to do a fellowship in general surgical pathology. And then from there, I went on to become the breast pathologist at the university. And so all I do is breast pathology, which basically means that I'm a surgical pathologist with a subspecialty in breast, although I could probably do the other fields. I have done them in the past, but I've been doing breast pathology for the last 10 years. So I interact with the breast pathology team. I receive the biopsies. I receive the surgical resections. There's actually a team of us. There's 3 of us. So we receive the biopsies. We receive the surgical resections. and then we make diagnoses and provide data relevant to the patient's care. And I'm going to give more details about what I do and what surgical pathologists do a little later on in this presentation. So that's the first type of first division under under anatomic pathology. The next division under anatomic pathology is called cytopathology. Cytopathology is essentially focused on making diagnosis from cells instead of tissue. So the primary mechanism by which cells are received in cytopathology is called a fine needle aspiration, where essentially they take a needle and take a very tiny needle, stick it into the tissue, remove a few cells, and the cytopathologists are able to make a diagnosis from those few cells. Additionally, another example by which cytopathology would receive tissue would be something called the pap smear. I'm sure you've heard of the pap smear. It essentially is a brush in which cells are removed from the transition zone of the cervix, and then those cells are analyzed under the microscope and with molecular pathology techniques as well, allowing a diagnosis to be made, of course, by the cytopathologist. So that's the second division of anatomic pathology. The third is autopsy. Honestly, autopsies are very rare nowadays. I know when a person thinks about pathology, the first thing they think about is autopsy, and the second thing they think about is forensics, especially if you watch any of the TV shows where they're forensic pathologists. But those two are exceedingly rare. I would say in a year, as a surgical pathologist at a university-based practice, like I am at University of Chicago, obviously, I probably do. Now we split the autopsies up, but I don't think I do more than 5 autopsies a year. And again, I really don't do them. I look at the tissues at the end after the, we have PAs, just like we heard about PAs previously. We have what are called pathology assistants. And so they'll assist with the autopsies, and then I'll come in at the end and look at the organs and help to organize the case. And so I'm involved in the beginning and when we're making decisions about how to proceed with the autopsy. I'll oversee the autopsy throughout the autopsy, and then I'll be present at the end when we review all the findings. And of course, we eventually put that together in a report that's useful for the patients and their treating physicians. But autopsies are relatively rare. And I can tell you that I, as an academic surgical pathologist, do autopsies, but private practice pathologists probably do far fewer. In fact, they may not even do any. And forensic pathology is very rare. I have nothing to do with forensic pathology, but of course that's more of a study of cases to determine the cause of death and try to provide evidence as to how an individual may have died. And so that's usually handled by a medical examiner's office. It wouldn't be handled in a community practice hospital or a private practice hospital. But we do rotate for a month through forensic pathology, so we do learn some of the basic techniques, but it is a separate fellowship, and it's not something that most surgical pathologists or most pathologists for that matter would be involved in. Okay, so that's anatomic pathology. Clinical pathology focuses on fluids. So for example, clinical chemistry, where fluid is removed from the body in order to test for analytes such as sodium, potassium, et cetera. That's all handled by clinical chemistry. As an example, we have hematopathology, which examines the blood and bone marrow and lymph nodes. And so if blood is removed for the purpose of studying the red cells or the platelets, or if blood is removed in order to exclude, for example, a leukemic process in the blood, that would be studied by hematopathology. Microbiology would look for the growth of organisms within tissue. So tissue may be removed or fluids may be removed in order to determine whether there's an infection or a known bug present, in which case microbiology would handle that specimen. Coagulation looks at coagulation factors within the blood, and the blood bank takes blood from patients and also returns blood, takes blood from donors and returns blood to other patients, and that also is handled as part of clinical pathology. So as a clinical pathology resident, when I did rotate, I did do a rotation through clinical chemistry, which is actually 2 months, hematopathology, which was 3 months, microbiology, which was 3 months, coag, which is a month or 2, and then blood bank, which is 3 months. And so that's the initial rotation. And then if anybody's interested in progressing beyond that, of course, they could do a fellowship in any of these areas. In a university setting, the clinical chemistry and hematopathology, microbiology, et cetera, are all handled by dedicated physicians who are devoted to those fields for the most part. So for example, we have dedicated attendings for microbiology, we have dedicated attendings for clinical chemistry, for blood bank, et cetera. However, in a private practice setting, where honestly most pathology occurs, usually what will happen is that you'll be a surgical pathologist and you'll secondarily have expertise in another area. So for example, you might be a surgical pathologist who also covers the blood bank, or a surgical pathologist who also covers microbiology. So that's often how a private practice setting might be organized in the case of clinical pathology. Like I said, there's kind of this third area, up and coming and rapidly growing area of pathology, which is called molecular pathology. This is a newer area that focuses on exam of molecules in organs, tissue, and fluids. And so that can be useful. Sometimes when you're trying to make a diagnosis, you could look for a translocation, for example. You may look for a particular gene mutation, rearrangement, loss of certain genes, gain of certain function, et cetera. All of that would be looked at by molecular pathology. And so they do assist in the diagnosis. They do assist in the treatment. They do assist in providing data that can be useful for treatment, particularly nowadays when you're looking for very specific mutations, which can be druggable. So we're looking for targets that can be treated with certain drugs that are designed for those drugs. And molecular pathology plays a really essential role in that. The old sort of the original foundations of pathology are certainly built on histopathology, which basically means that we look at an H&E slide and we make a diagnosis. I wouldn't be surprised if 30 to 40 years from now, we're much less focused on H&E diagnosis, and instead we're simply just molecular subtyping every tumor and then treating it according to its druggable targets. So that's kind of where we're headed. I think molecular pathology is certainly the future, one of the futures of pathology. And it's already here, and it's rapidly advancing. So kind of in summary, anything taken from a patient or anything returned to the patient will generally go through pathology. So any biopsy, any tissue, any blood, any serum, any transplant that goes back into the patient, eventually the patient themselves, in the case of autopsy, if they choose to have an autopsy, it pretty much goes through pathology. Pathology is going to have a role in analyzing it, in giving some sort of important information concerning the tissue, and then eventually that's going to be additive to the patient's care. So we really function behind the scenes. I think I have a slide on this later. We don't have tremendous interaction with patients, but we're kind of the underpinning of the hospital. Nothing can really happen from any perspective without some degree of pathology. Just imagine trying to make a diagnosis without any blood work or without being able to take a tissue, a tissue biopsy, for example. It just wouldn't be possible. And interestingly, we support everyone in order to allow them to be able to achieve the depth in their own field. So for example, most places, a surgical pathologist will be signing out breast pathology, gynae pathology, GI pathology, GU pathology, bone and soft tissue pathology, et cetera. And so it's interesting because the pathologist is going to be interacting with every single discipline, trying to speak with them in their own terms, in their own in their own usage that will best allow them to be able to serve their patients. And so it can get complex, but at the same time, it is subspecializing. And like I said, I pretty much only deal with breast, and it just goes to show you how subspecialized pathology has become. When I first started, which was like maybe 10 years ago, I actually was signing out breast and gynecologic, and I did some GI and I did some GU. But slowly over time, just the way medicine has gone, it's become more and more individualized, which has required pathology to also become more and more individualized. And so like I stated, I am a surgical pathologist with a subspecialty in breast, and that's pretty much all I do as far as my diagnostic and clinical work is concerned. I think I mentioned earlier that pathologists do complete a 4-year residency, which is followed by a 1-year fellowship. So this would be like an APCP residency followed by a 1-year fellowship. So for example, you could do a 1-year fellowship in breast. I did not do one, but that most breast pathologists actually would have a 1-year fellowship in breast. I just happen to have learned through experience on the job. Pathologists will work in community or academic settings to provide patient care. I've kind of hinted at that. So most pathologists out there are actually in a community setting where they're providing the same kind of care that you would in an academic setting. although academic settings sometimes can be a little more specialized. Interactions, like I mentioned, with patients are limited. Most of the interactions actually occur with other physicians. So we spend a lot of time teaching other physicians. We spend a lot of time providing data to other physicians, communicating with other physicians, and they in turn will then use that data to communicate what they would like with the patient. So interactions with patients are fairly limited. I do see patients on occasion, particularly when they would like to come and look at their slides with me or talk over the findings. So I do have circumstances where I will meet with patients. Some spheres of pathology do meet with patients more than others. For example, I talked about cytopathology earlier. They actually will engage with patients regularly. They'll regularly see patients because they're the ones that do their own biopsies. But for them, sometimes bone marrows are also done by hematopathologists at some institutions. But for the most part, it's really interacting with the physicians, not directly with the patients. And the physicians will provide us with the key data, and then we'll provide them back with clinically relevant data that can be useful for treating their patients. This is just an example of one of the interactions that we commonly have. This is not taken from the University of Chicago, but we have a similar interaction. I just happen to find this picture very easily online. And so what's being depicted here is you can see that there's an audience of physicians. You notice all the white coats. And so there's residents, there's physicians of different disciplines. There's PAs, there's nurses, there's geneticists, there's a whole slew of different people that will be involved in a multidisciplinary tumor board. I'm going to talk a little bit more about that in a moment. On the right over here are the imaging findings. It so happens that there's a mammogram on the screen, and so they're showing the imaging findings in this particular patient, which happen to be findings in the breast. And on the left is a histologic image, which is being shown by the pathologist. This histologic image happens to show ductal carcinoma in situ. And so this is an example of the types of correlations that will occur. In the end, the final diagnosis is always made by pathology. So it doesn't matter what others think. What others think can give you a differential diagnosis, but without a tissue, no additional action can be taken. Sorry, without a tissue diagnosis, no additional action can be taken. So for example, on a mammogram, you might find calcifications, but it's important to remember that those calcifications can represent multiple or a myriad of different processes. For example, calcifications on a mammogram can be benign. They can be malignant. In about 30% of the cases, they're malignant, but in about 70% of cases, calcifications on a mammogram are benign. There's no way of being absolutely certain. The only way to be absolutely certain would be to take a piece of tissue, arrive at the pathologic slide, put that under the microscope, and then make a final pathologic diagnosis. So the ultimate diagnosis always requires tissue. It doesn't matter. No, there's no other way in which a diagnosis is made except through a tissue biopsy of some sort, and only then can action be taken. Everything else would be conjecture until an absolute diagnosis is made by pathology. And similarly, when we stage patients for cancer, as we're going to speak about in a moment, it also is dependent on a final pathologic stage, as I'm going to highlight in a moment. Additionally, other things that pathologists are involved in an academic setting, pathologists like others are also involved in research and education. Given our access to tissue and given all of the interest that we have in etiology and also in trying to find factors that can allow us to both give prognostic and predictive implications for patients, academic pathologists are often involved in research and or education. Most pathologists in the Department of Pathology at the University of Chicago are involved in both research and education. You probably interacted with pathologists already as part of the early coursework that you've had at Pritzker. You're going to continue to interact with pathologists in the second year, and then beyond. No matter what field you go into, you will have a deep interaction with the pathologist as far as your field is concerned. But this is basically how academic pathologists function. They'll kind of wear the clinical hat. They also wear a research hat where they're engaged in research to try to advance understanding whatever disease processes that they're involved in. And then they're often involved in education, whether that be usually with medical students, but it may even be at more advanced levels as well. Okay, so that's kind of the first part of my presentation. I'm going to pause there and let you ask any questions if there are any. Maybe just a couple so that we can continue on. I'm not able to see the chat if anything happens to be showing up.
I'll let you know. Yeah, if students, if you have any questions, feel free to type it in the chat box. We could probably keep going and maybe questions towards the end.
Okay, perfect. Not a problem. So now we're going to move into pathology and its direct role in oncology. So oncologic care, as I'm sure you've gained from these sessions over the past several weeks, is multidisciplinary. And what that means is that uh, in order for proper oncologic care to be delivered, it's contingent upon multiple players all being experts in their own domain, which then comes together in a additive fashion to allow for a final decision to be made as to how to proceed with the patient. And this is exceedingly important. There is no one discipline that makes up oncology. Oncology is contingent upon a whole slew of disciplines. You can't have oncologic care without good radiology. You can't have oncologic care without good radiation oncology. You can't have oncologic care without good PAs and nurses. You can't have good oncologic care without geneticists. You can't have good oncologic care without patient navigators, nurse practitioners, surgical pathologists, molecular pathologists, clinical pathologists, surgeons. I'm sure I'm missing some, oncologists, et cetera. All of these fields are essential in order to be able to provide excellent oncologic care. And why you have all this sort of like division of labor here is because the degree of expertise that's necessary is so specialized that without having a series of people that are all experts in what they do and all highly professional in what they do, you just can't produce the best oncologic care. I can tell you that we have, as a breast pathologist, I'm part of a multidisciplinary breast meeting, which occurs once a week on Thursday mornings. We start at 7:30 in the morning. We end at 10, so it's a 2.5-hour conference. We discuss every single patient that comes through our system that is going to get some type of oncologic care. So it's fairly exhaustive. We have 20 to 30 patients a week. Let's say on average 25 to 30 patients on any given week that we discuss. And it's actually a slew of people that are involved. We have close to 40 people, I think 40 to 50 people on our mailing list. And in any one meeting, we'll have up to 30 to 40 people in the room, all chiming in, providing data that is relevant to the patient and patient care. Now, not only is this subspecialty necessary within multiple disciplines, but it's also necessary within the discipline of pathology itself. So as I mentioned earlier, AP or anatomic pathology, CP or clinical pathology, and molecular pathology all play important roles in oncologic care. And so we have subspecialized people dedicated in AP, particularly the surgical pathologists, that are playing an essential role in oncologic care for patients. CP as well, molecular pathology as well. So for example, certain tumors release markers into the blood. I'm sure you're aware of this, which can then be used. These are serum tumor markers, and these serum tumor markers can be used for screening. For example, one of the ways by which we can screen is we can look for PSA in the blood. And so in order to be able to get a result on what's happening with the PSA, in order to be able to have a comparison as to what's normal, what's abnormal, in order to make sure that the testing is done properly, in order to make sure that you've got appropriate ranges and that these tests are validated, there's a clinical pathologist behind the scenes that's watching every single one of these tests and releasing these results in order for clinicians to be able to act upon that data. Similarly, that PSA is also useful for response to treatment. So for example, when a patient has a PSA and it's 30, and then you subsequently give the patient chemotherapy or a surgical resection, and you reassess the PSA to see if the patient responded to the treatment, that's also going to, obviously clinical pathology is going to play a role there. And then in detecting recurrence, if a patient has a prostatic carcinoma that has a high PSA, you treat them, the PSA goes down, they seem to be doing well, all of a sudden they come in with some new symptoms that are worrisome for a recurrence. One of the ways to detect that recurrence, or at least one of the first ways to sort of go about detecting that recurrence, would be to then do the PSA again to see whether it's gone up all of a sudden, which could then suggest that the patient might have a recurrence, and then maybe a tissue diagnosis might be further made in order to prove the recurrence. So what I'm trying to highlight here is that I've just given you a simple example, but this is to show you that there's a lot going on behind the scenes. So for example, this is just I'm just posting on the screen here an example of a PSA, which is of course the prostatic specific antigen that can be elevated in patients with prostatic adenocarcinoma. And just to give you an example of a report, the report's looking at the free PSA, it's looking at the total PSA, it's providing a range, it's providing the fact that it's out of range. Here's the reference range for the laboratory as an example. It's giving you some estimated, probabilities of cancer risk. There's these references here. It tells you some information about the assay. It tells you about the variability in the findings depending on the age and the ethnicity of the patient, et cetera. So, it's telling you the machine that was used. All of this requires a degree of expertise, and it requires a physician who understands the relevance of the PSA, who understands the limitations of the PSA, who understands the variability of the PSA, how the PSA is looked at, the machine and how the machine's analyzing the PSA, et cetera, in order to be able to provide clinically relevant data that's going to be actionable by all of the people that are going to rely on that PSA, from the patient to the surgeon, to the oncologist, to the radiation oncologist, to the imagers, et cetera, who are all, sort of taking that PSA data and then applying it to how they're going to analyze and further act upon the patient's findings. As another example, certain tumors are more prevalent in the blood than in tissues. And so those tumors are going to be more dealt with by the hematopathologist. And so here's an example of an acute lymphoblastic leukemia, which we summarize as ALL, or we use these letters ALL to indicate this disease. So this is a disorder, a leukemic process, which is a malignancy that arises from the bone marrow, the stem cells in the bone marrow, and eventually is going to be present in the blood. And so in order to make a diagnosis of ALL, often a blood smear is taken along with a bone marrow biopsy. And so you can see this is a blood smear because these here represent red blood cells. But what's abnormal here is these very large atypical cells, which are just way larger. They're way larger than normal. And they contain some characteristics which you're going to learn about as you move forward into CPP, which allow a diagnosis to be made of ALL. Now, this diagnosis of ALL can be suggested by the blood smear, but then there's additional molecular studies that are going to be done in the section of hematopathology, which will allow a diagnosis to be clinched, and also to be able to look for some molecular translocations or gene rearrangements that may be present, particularly chromosomal anomalies, that could also be useful for both prognosis and determining how to treat the patient. So here we have an example where a hematopathologist and a molecular pathologist might play an essential role that's going to drive all this additional effort by oncology, imaging, patient, et cetera. Much of oncology is centered around surgical pathology. So I did give you two examples of how the labs can be involved. Like I just gave you an example of clinical pathology and hematopathology, but much of oncology currently is centered around surgical pathology. And surgical pathology is going to play the following roles. And so I'm just going to quickly highlight what we as surgical pathologists are trying to do. Number one, we're trying to establish a diagnosis. So what this means is that the particular clinician, whether that be a surgeon or an imager, a radiologist usually, so these are the two people that we usually get biopsies from. So the clinician is going to provide us with a differential diagnosis, a history, a very brief HPI, any relevant past medical history. All of that's going to be submitted along with a piece of tissue, and that's going to allow us to be able to make a diagnosis to ascertain exactly what disease or type of disease the patient might have. So here's how we would make a cancer diagnosis, for example. Another important role that we play is we confirm adequacy of resection, which basically means that if there's a surgeon who's trying to remove a cancer, that en bloc removal of the cancer will be sent to pathology. Pathology will then analyze that tissue to determine and confirm that it's been adequately resected by the surgeon. And then finally, we analyze the tissue and we analyze the cancer to provide prognostic and predictive factors. Now for each of these, 1, 2, and 3, I'm going to go into a little more detail in the subsequent slides. So how are diagnoses made? Diagnosis is always going to involve tissue sampling. You can come up with a differential diagnosis by doing a physical exam. You can come up with a differential diagnosis by doing imaging. You can come up with a differential diagnosis by doing some blood work. However, the final diagnosis, the final absolute diagnosis is going to usually, in oncology, is going to usually involve tissue sampling. So the tissue must be sampled in a few different ways. So here's some possible ways. One way is called an FNA, or fine needle aspiration. This is where you take a tiny needle, you stick it into the tissue, you remove just a few cells, you spread them on a slide, it gets sent to a cytopathologist whose specialty is looking at cells, and they'll make a diagnosis of cancer, for example. You could also do something called an incisional biopsy. What that means is, let's pretend that the square that I'm drawing on the screen represents the tumor. You simply take a little bite of that tumor and you analyze it. You then remove it from the patient, you send it to pathology, and then that is then analyzed by pathologists to then provide a diagnosis and perhaps some additional details. You can do something called an excisional biopsy, where again, let's say this is the tumor, but instead of taking just a little piece, through a biopsy, like a needle biopsy, you might actually excise a piece of it. So for example, let's say you surgically excise this half the tumor as an example, and that's called an excisional biopsy. Instead of removing a tiny piece of the tumor, you remove a big excisional piece of the tumor. And then finally, sometimes we make a diagnosis by surgical resection. So let's pretend this is the tissue and this is the tumor here. The surgeon might actually go in and resect the entire tumor area without a diagnosis, but in order to try to achieve a diagnosis, and that's a surgical resection. So these are the 4 common ways by which we receive tissue, and this allows us to make a diagnosis and also to provide some additional details that can be useful for treating the patient. Here I've just given you an example of what a fine needle aspiration might look like. So it's often done on the thyroid. Now, it's not only done on the thyroid. I'm just giving you an example here. So pretend this is a patient who's got some sort of nodule in the thyroid, and we're trying to determine what that nodule is. So if we have a concern for cancer, then we're going to need to take some tissue to confirm or exclude that possibility. And the most common way by which tissue is taken from the thyroid is called a fine needle aspiration. So what they do is they stick a little needle into this tumor, they pull out some cells, they put them on a slide, and they analyze the cells using the help of a cytopathologist. So the cytopathologist would make the diagnosis here. Remember I spoke about the second role that surgical pathology plays, which is adequacy of resection. The way that works is illustrated in this picture here. And so what this is, and I'm going to have to bear with me just to explain what's going on here. This is a patient with a breast cancer. So imagine this is the chest wall and this was the breast. And let's pretend that this is a tumor in the breast. So this patient, the surgeon went in and removed a square of tissue. When you remove a lump or a square of tissue, we call that a lumpectomy. So this would be the cancer, and this bigger piece of tissue would be the lumpectomy. So what's happened in this particular instance is that this patient has undergone lumpectomy. So this entire piece of tissue represents the lumpectomy. So the cancer, for example, might be present in the center of this lumpectomy. Now, the next thing that happens is when we receive a lumpectomy, we need to determine adequacy of excision. So the way that we determine adequacy of excision is that we ink the specimen. So the reason this has all these different colors on it is because we've taken this specimen and we've colored it with different colored ink. So notice the blue ink here, the orange ink here, the red ink here, the yellow ink here. And we do this in 6 colors. Now, each of the inks represents a margin. So for example, we have a superior aspect of the specimen, an inferior aspect of the specimen, a lateral, a medial, anterior, posterior. So those are 6 different dimensions to the specimen, right? Anterior, posterior, lateral, medial, superior, and inferior. And so what we'll do is we'll take 6 colors of ink. We'll ink these 6 colors. Sorry, let me just turn this off. So we will ink the specimen 6 colors, and then we'll basically put this under a microscope, and we'll analyze little pieces of the tissue and look at the ink relative to the cancer. So for example, when I'm looking at my slide, and this is now a little schematic here, let's do it this way. This is a little schematic of the slide. So let's say this is a slide here, and this is my little piece of tissue, and there's blue ink here. And on my slide, I see cancer, okay? And I see that it's this much distance from the blue ink. So this is how I would determine that I've adequately cleared the blue ink. And the blue ink, let's pretend for, as an example, a blue represents superior. And so this would allow me to confirm that the superior margin is indeed free. And so I'll do that with all 6 margins, and I'll be able to determine adequacy of resection. Now, this is very important because in this particular instance, what's happened is that the patient needed a surgical resection as the next best step in their treatment, which basically means that I need to confirm that that surgical resection is adequate, that indeed, if the goal was to remove the entire tumor, that the cancer was actually completely removed from the patient. And I'll tell you that in about 5 to maybe 10% of cases, I will find tumor at a margin here or a margin here, because maybe imaging underestimated the tumor, or maybe the tissue was rearranged in the process of the biopsy. And so we didn't get exactly a complete, adequate understanding of exactly where the tumor was centered. So it is very useful for patients to be able to know that their tumor was completely removed. And if, for example, a margin is positive, we call it a positive margin, then the surgeon can simply go back and just remove additional tissue at the region of the margin. So this is particularly helpful when a patient wants to conserve their breast. So for example, if a patient has breast cancer and the breast cancer is only located here, the nice thing about breast cancer treatment today is we don't have to take the entire breast. Now, historically, 30, 40 years ago, we would take the entire breast. But nowadays, we can conserve the breast by just removing only the area of cancer. But again, if you're going to remove only the area of cancer, you must ensure that you left no cancer behind, which is where the surgical pathologist will come in. Another important feature of what the surgical pathologist will do is that they'll be able to provide prognostic factors and predictive factors concerning the tumor. So prognostic factors are attributes of a tumor that define its behavior. And these are classically captured by a system called the TNM classification system. T stands for tumor, which basically refers to the tumor size or the depth of invasion. The N stands for nodes, which basically implies how many nodes are involved regionally. And M stands for metastasis. And I think you should have covered this in your GenPath course. But if not, you're going to hear a little more about this in a moment. So TNM, there's 2 types of TNM. There's a clinical TNM, which basically is dependent on clinical exam and imaging. And then there's something called a pathologic TNM, which is dependent on the final analysis of the tissue. The clinical TNM initially drives treatment, but at the end, it's the pathologic TNM that's going to be the final stage for the patient. So the pathologic TNM is essential for determining how patients are going to be handled. The way by which each individual organ has its own different criteria by which the TNM is going to be determined. And all of that's placed in this cancer staging manual, which is published every few years. We're currently on the 8th edition. This is actually a hardcover book that is probably, 300, 350 pages long. It's divided into sections based on each organ. And then based on the organ, you'll then determine how you can produce the TNM. T is usually going to be based on tumor size or depth of invasion. So if you have a solid organ, for example, in the case of breast, let's say that's a cancer there, you're going to ask how big the tumor is. And so it's going to be based on size. Where if you have like a organ like the bladder, then you're going to determine how deep that tumor invades into the bladder wall. So the T will be based on either the tumor size in solid organs or the depth of invasion in hollow organs. Here's an example just to highlight that. Here is breast cancer. It measures about 5 centimeters. We can confirm that using our histologic slides and our gross examination. And so this would get a T stage based on size. Here's an example of bladder. And what you can see is here's T1, T2, T3, T4. And the higher the number, the worse the tumor stage. But notice that here's the inside of the bladder. Sorry, this is the inner aspect of the bladder. This is here. And so you can see here, you've got, an early stage tumor, and it's getting deeper and deeper and deeper. And now it goes through the entire wall. And we would call that T4. So what I meant to highlight by this image is to show you that T stage can be based on either size or depth of invasion, depending on the organ system. Now, this is very important because it provides it's a prognostic factor, which basically means it's going to suggest how the tumor might behave in the patient. Based on that, you can predict survival, and you can also determine how aggressive you want to get with additional treatment. So just as a very quick example, how important size would be from a pathology perspective. If a tumor is between 1 and 1.9 centimeters, they have a very high 5-year survival if their nodes are negative. Whereas if the tumor is larger than 5 centimeters, you can see that their survival goes down a little bit based on whether their nodes are negative or whether their lymph nodes are positive. And the presence of this distinction between lymph node negative and lymph node positive is highlighting the second point concerning the TNM staging, which is that we do care about the involvement of the local regional lymph nodes. The N specifically refers to regional lymph nodes. And so based on the particular organ, we're going to decide which nodes are important. So for example, in the breast, the most important nodes are the axillary lymph nodes. With the prostate, you might look at the pelvic lymph nodes, just as an example. So the N represents nodal involvement. And nodal involvement is also going to affect survival. This is a very simplistic chart. The data has changed, but I just want to show you that if you have no nodes, you can see this is the survival curve. Whereas if you have greater than 4 nodes, you can see that this becomes a survival curve over time. So you can see that survival becomes less likely if nodes are involved, and particularly if many nodes are involved. And the final part of the TNM classification is metastasis, which basically means distant spread. And this would usually portend a poor prognosis and may be handled very differently depending on the different treatment options that are available and how the patient would like to proceed. Now, those are your 3 main prognostic features, the T, the N, and the M. And additionally, we also provide histologic grade and subtyping, which varies by the organ system. So for example, here's a picture of prostatic adenocarcinoma. So this is a patient that has adenocarcinoma of the prostate. And the way by which we grade adenocarcinoma of the prostate is we use something called the Gleason grading system. You're going to hear more about this as you move forward into CPP. But it's based on the architecture. So for example, if we see small uniform glands, as is highlighted here, that would be a grade 1. Whereas if we see lack of glands and sheets of cells, that would be a score 5. And so we do look at architecture and the cells themselves. Depending on the organ system, it varies depending on the type of tumor to try to determine a grade. And the grade will also be important for prognosis. We also determine predictive factors. Predictive factors are factors that predict response to treatment. So for example, in the case of breast, we will look at ER, PR, and HER2. These are key factors. And why we look at these, because if a patient has breast cancer that's ER and PR positive, they might respond to anti-estrogen agents. And if they have breast cancer that's HER2 positive, they might respond to specific antibodies against the HER2 growth factor receptor. The way by which we determine the presence of these is by doing something called immunohistochemistry. So this is on the left is an immunohistochemical stain for estrogen receptor in the nucleus. So this is the cancer. We can see the brown staining in the nucleus of the cells, indicating that these cells express estrogen receptor, which would then suggest to the oncologist that perhaps they could treat with an anti-estrogen agent to reduce the future risk of recurrence or distant spread in this patient. Here's another example of a cancer. This is breast cancer. These are all cells. And you can see that these cells have a little brown ring around them. The brown represents the antibody. And these are overexpressing a growth factor receptor, which is called HER2, which would also then indicate a specific type of treatment. Just as a newer example, we can also look at PD-L1. PD-L1 is a ligand that can be present on a tumor cell, which binds PD-1, which then inhibits the T cells from killing the tumor. And so if we block that interaction by giving an anti-PD-L1 molecule, we can then we can disinhibit the T cell shutdown, which would then cause the tumor to get killed. So this is another type of predictive factor that we can study. Here's an example where this patient expresses this is the patient's tumor. It expresses PD-L1, which basically means that this molecule could be blocking the T cells from killing the tumor. So we might give an anti-PD-L1 molecule, which would then allow the T cells to kill the tumor in a certain subset of different types of tumors. So this patient might respond to immunotherapy, for example. This patient has no PD-L1, and so this patient might not respond to immunotherapy. Again, molecular studies are also useful. And as I mentioned earlier, these are kind of new and upcoming, and they help to both predict, they help to both provide prognostic and predictive factors. Here's an example. This is a messenger RNA expression profile, which allows us to subtype breast cancer differently than we've normally been doing. So historically, we would classify breast cancer as ductal and lobular, and we would also classify it based on whether it expresses ER or PR or HER2. And this study was an early study that showed that you could actually subclassify breast cancer based on expression profiling. So they look at their messenger RNA, they look at what what messenger RNAs are increased, suggesting that the genes are more transcribed, which ones are decreased, and then they found these various pockets. This is pocket 1, pocket 2, pocket 3, pocket 4, and they were then tried to subclassify breast cancer accordingly. This is just one of many possible ways by which you can subclassify some of these prognostic factors, but I think it's important to remember that just because you can do something that looks cute and looks very colorful and may even be valid scientifically, it's not helpful unless it meets a few important criteria. Number one, the findings have to be statistically significant, obviously. Number two, they have to be independently valid. But number three, it has to be clinically relevant. So honestly, this is a beautiful study here on the screen, and it kind of excited the breast pathology and breast cancer world for many years. But to date, we have yet to be able to use this clinically because it doesn't provide clinically relevant data that goes beyond the factors that we already provide. So, in order for a factor to be useful, it can't just be interesting in the lab. It can't just be interesting theoretically. It needs to be proven to be clinically useful and clinically relevant in the care of patients. So when you apply that criteria, there's only a handful of parameters that are going to be included in a staging report. So this is an interesting article that came out regarding the gene expression profiles that I just showed, which eventually was establishing that the old clinical markers that we used are very similar in power to the microarray gene expression profiles. And so just because something's new, it doesn't necessarily make it better. Just as a last slide, this is the, anytime we receive a surgical resection, we do provide a summary of all of our key findings. And usually with any cancer, you're going to get what's called you're going to get a pathologic parameters. In this case, this is breast, but this is a pathologic parameters. And essentially it's going to provide key information. For example, the tumor size, which is going to allow you to determine the T, the regional lymph node involvement, which is going to allow you to determine the N. We don't comment on metastasis here, but if metastasis was present, we would put it in the stage by giving them something called an M1 stage. Similarly, we're going to provide a histologic grade. So this is going to give the grade. We're going to provide the key studies. Notice that it's ER, PR, and HER2. So these are your predictive factors, which will then allow you to know what's the best way to go ahead and treat this patient. Notice here we provide the margins, which is basically going to give you information about the surgical adequacy. Did the surgeon adequately remove the tumor? So all of those things that I kind of hinted at in this presentation, they all get summated in this parameter sheet. And I know most of you are not going to become pathologists. Perhaps some will, but obviously not all. But all of you, if you go into oncologic care, or even if you're not in oncologic care, you're going to come across these pathologic parameters. And it's important for you to know that in these pathologic parameters, the pathologist is providing key relevant data for how the patient can be treated, and the prognosis of the patient with their tumor as is without receiving treatment. And this, honestly, I could give a 4-hour lecture just on this parameter sheet, but the goal here is to just introduce you to some of these basic principles that are present in pathology. So my summary slide here is what I kind of started with as far as oncology is concerned, and that is that clinical oncology is multidisciplinary. It requires the expertise and the professionalism and the hard work and dedication of sacrifice of multiple people from multiple disciplines, some of which are physicians and some of which are not physicians. And each discipline seeks to provide relevant data and care while working to expand its own horizons. So pathologists are always trying to expand our horizons. Oncologists are trying to expand their horizons. So each discipline is trying to provide relevant data and care while also working to expand to provide new information that could be clinically relevant moving forward. And so, it's an honor to be able to introduce what pathology does. You're obviously certainly going to get a lot more introduction to pathology as you move along in your careers. I hope some of you will consider even rotating through pathology just so you can get an understanding of how this data is being generated. I think it's really important for anyone who is dealing with patients to know where this data is coming from. And if any of you along the way would like to spend time in pathology, you're more than welcome to. Just contact us. We would be happy to host you for however long you would like to be with us, and for whatever area you would like to gain additional expertise. So I'm going to stop there. If there's any additional questions, I can take them now.
That was great. Thank you very much. We had a few questions come in. First one was, how often is there disagreement on the tissue diagnosis of a sample?
Okay, excellent. So I would say like 90% of pathology is bread and butter. Bread and butter meaning that if you're trained in pathology, you should be able to make the diagnosis. There's about 10% of the times where you're unsure, or you're kind of in between a couple possibilities. So what happens there is that we have something called a QA meeting every day at 2 o'clock. Now it's a little less common because of the virus issues, but in general, historically, we've had this 2 o'clock meeting where we have this multi-headed microscope. There's 18 heads, and also there's projection on a large screen. We all get together in a room and we show the difficult cases of the day, and everyone kind of chimes in, and then we're able to come to a diagnosis, just by consulting one another. So within breast pathology, I can tell you that 90% of the cases, I kind of just make the diagnosis on my own. Another 10% of the cases, I probably show around to the other 2 breast pathologists. And then a rare case, maybe once every 6 months, once every year, we might send it out to an expert who might be like the world's expert in quote unquote breast pathology. But for the most part, we're able to make those diagnoses. Now, sometimes there is disagreement, particularly from the outside. The case will come in from the outside and I may not agree. In which case we might do additional studies to try to present our opinion, or we may state that there is no absolute. Everything's not black and white in medicine, as you're all aware. So I may look at a slide and think it's kind of in between 2 possibilities, and I'll just present both those possibilities so that everyone can then kind of move forward in how to best handle the patient.
Great. Another question was, have there been any efforts or successes in applying machine learning and image processing to pathology?
Yeah, that's an excellent question. So that's up and coming. Honestly, we're a little behind in that because we predominantly use glass slides till this day. And so the digitizing of these images is not as quick as it has been with radiology, for example. And so in the case of pathology, we're now, over the last, I would say 5 years, beginning to digitize all this stuff, and machine learning and what's called informatics. That's a special subsection of pathology, which actually you can do a fellowship in, and you actually do a rotation in as a resident, is kind of expanding that horizon, but we're certainly not anywhere near it yet.
Great, thanks. And then one more question that came in from Kevin is, do normal ranges of tumor-specific antigens differ between populations? And if so, how are these differences accounted for when diagnosing non-Caucasian populations?
Sure, excellent question. So yes, they do vary among populations. They do vary among, not only even among populations, but among labs. So some labs are located in one part of the country and some labs are located in another part of the country. Some labs are located in different parts of the city. And of course, different demographics are going to be present. And so what will happen is we normalize those values according to volunteers at our institution. So as patients come in, we will recruit a certain number of volunteers. We'll then test those samples. We'll provide a range based on those samples. It needs to be within the overall range that's nationally acceptable. And then we'll sort of work with that. And wherever there could be, any room for variation, we'll also put a comment in stating patient's age, patient's ethnicity, et cetera, can have an effect on these results.
All right, actually another question just came in from Maria. I'm wondering, how do you think the pathology reports should be shared with patients? While shadowing once, I noticed that the surgeon just read off a part of the report to the patient. As a medical student, I didn't understand. So I was wondering if that was the best way to deliver the report findings.
Yes, excellent. So Yeah, I mean that's a big discussion in pathology. It's actually a really good question. We obviously the report's available to the patient because the reports are uploaded into Epic, and patients do get access to the reports from this system called MyChart. But I will admit that the vast majority of patients don't understand the pathology report because of the highly technical nature of the fact of the way that we provide the data and the terms that we use. And so even dealing with my own relatives when they're, they'll kind of present me this pathology report and they won't understand fully what is present in that report, and I'll need to translate it for them. There has been this movement in pathology and even from among the surgeons to provide what we call a patient-centric report, where maybe there's a cover sheet that in a more patient-centric way explains the findings in a maybe in a few sentences. There is discussion about that. It hasn't become mainstay, mostly because the data present in the report is really going to be translated by someone, whether that's the surgeon or the oncologist. And so for that reason, it hasn't fully picked up, but there has been talk about that, and it's certainly an issue. At least the basics of the report, should be understandable by the patient. And so, yes, that is something that's currently being discussed and worked on.
Yeah, I think it's interesting with patient medical records being so much more accessible. Like all of my patient notes, I now share with all my patients, although I don't think a lot of them access them. But pathology reports are a good example of if you just share it as kind of the raw pathology data, the patient can't interpret it without kind of a translator. So
yeah, definitely, it's certainly an issue.
yeah, well, I think that's probably a good place to stop. I would just maybe end by saying that pathology is something I did a rotation as an intern, not as a student. And it wasn't until I did that I appreciated how much work goes into finalizing a pathology report. So like Dr. Sattar showed you, there's the processing that occurs, waiting for the slides to stain, QA committee to make sure that they agree. So, I have colleagues that are like, oh, why is the pathology not back yet? We did the procedure yesterday, and I'm sure Dr. Sattar's probably gotten a million phone calls. Is it ready yet? Is it ready yet? But no, it's I think a great specialty, and like you said, it really is multidisciplinary. So, all right, well, that is the end of our last SOAR seminar. So thank you so much, Dr. Sattar.